And thank you for all coming and inviting me back. And for those who I have the privilege of taking care of, thank you for that. And it's wonderful to see all this red. It is. So I thought tonight we would try to explain some of the issues related to heart disease in women, because heart disease in women is distinct from heart disease in men, which we historically have known a lot about because many of the studies done with heart disease were in men, either VA medical centers, military, or just because we enrolled more men than women because we thought heart disease was more prevalent in men, which is not always true. So I thought we'd describe the problem as it relates to women, discuss some of the risk factors for developing the problem. I feel sort of like I'm preaching to the choir because I think this body probably knows better than those who didn't come tonight. Consider some lifestyle change which affect the risk of developing the problem, and then I take any questions. And throughout the talk, if there are any questions that you would like to ask, please feel free to raise your hand. So this is a slide describing the mortality trends, the death, women in white, men in red, over time between 1979 and 2001. And you can see how through what we would like to take credit for, interventions and life-saving measures we've taken, we can affect men, but we haven't done very well with women. And this is a curiosity which is now recognized, and we're recognizing more that women who have heart disease are much different than men, respond different to therapies, and we have to take a different thought process in the management. If you look at younger populations, men have more coronary disease than women. So you can see the red bars are distinctly higher than the white bars until about 65. And then the white bars start to become higher. Now, women do live longer than men, so as time goes on, the prevalence of the disease will get higher. But you can see that heart disease in women tends to occur later. At the time it occurs, there are different processes going on physiologically, so the management of women should be different than men. But it's important to recognize it's very prevalent in women. It's the #1 cause of death, above all cancer. If you look at how women do after a heart attack, in younger age groups, women fare much worse. Their mortality is double that of men. It's a different disease. We may manage it inappropriately or suboptimally. And although we think we understand how the disease process is by gender, I think we don't understand it very much. After about age 75, it doesn't matter. The mortality is about the same. But this spread here is the most interesting. So women less than 65 have twice the mortality rate. After MI, women have higher rates of depression and physical disability. Even after bypass surgery, which we consider a very useful treatment for coronary disease, women come to the hospital more frequently with heart failure, recurrent chest pain, and I'll show you some of the reasons we think this is true. But again, a lot of this is observational. It's never been tested scientifically, but it clearly is a phenomenon. They have reduced mental health and physical functioning, which means the therapy affects them more adversely than men. Now, so we went to look in the past, why is that? What is it that we're doing that causes this differential survival, this differential outcome? Compared to men, women used to get less clot-busting drugs. Now, you know, with these angioplasties and stents, they're using a lot less of these clot-busting drugs, but we were more apt to give it to a man. Some of that, I think, was gender bias. Some of it was fear that women would be more prone to bleeding because they're smaller and perhaps, you know, it was too aggressive a therapy. And I'm sure all of those factors played a role. We were less likely to take women to the cath lab. Now, some would say, well, maybe they shouldn't go, maybe they don't fare as well. And that's probably true, but that doesn't mean you deny that therapy. And it's been shown time and time again that if you do deny the therapy, that they actually do a little bit worse. They were less likely to get surgery. So there was this sort of inherent bias not to take a woman to surgery because, again, they're smaller, their hearts are smaller, their vessels are smaller, maybe it would be less likely to help them. And a lot of this is just natural bias, unscientifically proven. But this was shown to be true in studies. Now, it's true that with procedures, they do have a higher complication rate. They've attributed this to smaller artery size, the fact that as women present with heart disease, they tend to be older. We saw that graph with the prevalence rising. And so there's a lot more coexisting disease, diabetes, renal disease, calcification in other arteries, things that portend a higher complication rate. There's a higher rate of diabetes. They tend to present more urgently. Women in the past have tended to deny their symptoms. Last week I had a patient, she went down to do the laundry, and it wasn't until she started sweating bullets that she decided to call the ambulance. Women have a higher incidence of heart failure compared to men due to stiff hearts. This is not very well understood, and it is a true phenomena that in addition to having a weak heart, if you have a heart that is stiff, you can develop heart failure, and this is much more common in women, and we don't know a lot about that process. Now, how about testing? So someone comes in, they have chest pain. You're saying, well, do I have coronary disease or not? This is a typical chest pain. Women present differently than men. Unfortunately, one of the more common imaging modalities that had been used in the past was where they would run you on a treadmill or inject something in your arm and then put you under a camera and try to take pictures of the blood flow in your heart. Well, women have smaller hearts than men, so the test was less accurate. So the accuracy rate of 93 versus 87 was attributed to women having smaller hearts, and just the images couldn't contrast the lack of blood flow well enough, which is a problem. Now, with respect to congestive heart failure, why do women get shortness of breath and systolic and diastolic heart failure? Well, they tend to be older, and when they do get older, they're more likely to have high blood pressure, diabetes, and this dread diastolic dysfunction, which you will be reading more and more about. And many people who go to heart failure clinics now actually have very strong hearts. They're just not so amenable to relaxation. And we still don't know how to relax that heart. There's many reasons for it. We know it's hormonal, it's due to blood pressure. It's just we don't have very good medications to allow that heart to relax and fill with blood. Again, our knowledge is limited, so unfortunately, women have more of this process, which we don't know much to treat, except the dread water pill, which we push on everyone to get rid of the fluid in the legs and allow you to sit up without being short of breath all the time. It's important to realize that across groups, blacks, Hispanics, Latinos, women have the leading cause of death is heart disease. It is. It's not select to any specific group. African women are the highest because they tend to have the highest risk of diabetes and hypertension, which makes matters even worse. So how do you approach prevention? Because we know that once the disease happens in women, they do worse. They do worse psychologically, physically, and even with our interventions, the stents, the bypass surgery, all of those wonderful things we expound to do, they don't do as well. So how do we prevent it? I mean, basically, what you've done tonight by coming out expresses a lot of this. So you try to assess and stratify who's high risk, who's low risk, who's intermediate risk. What's my risk? How do I alter my lifestyle in a way that would be beneficial to reduce that risk? What is it really that I should do? Do I have to train for a marathon? Can I just walk 20 minutes a day, 3 days a week? Is that enough? I think so. Other interventions like the treatment of high blood pressure, diabetes, and the dread cholesterol. The highest priority should be for the highest risk patients. At least we believe that, because like life insurance, you want to insure that person who's at highest risk. We want to intervene on that person who's at highest risk. So you try to codify people to say, look, you can diet, you should be taking Lipitor, you should be exercising more, you should be losing weight, and please don't smoke if you do. Avoid those factors which are sort of propaganda. There's a lot of therapies out there, and I'll mention a few of them, and I'm sure some of you are on them, and they probably do no harm. But things like folic acid, omega-3 fatty acid, krill oil, those things that we sort of wish over the years that had really made a huge intervention that really don't seem to do much at all. And avoid those things that are actually harmful, like hormone therapy, which we espoused for years for the treatment to avoid heart disease. So what are reasonable goals? I mean, I think it's reasonable to ask your doc, is my cholesterol under 200? Or I should strive towards that goal. Is it a magic number? No. But if you draw a curve for events, 200 seems to be a reasonable cut point for total cholesterol. It would be wonderful, although unlikely, to have everyone's blood pressure 120 over 80. I think that's a bit of an optimistic look, untreated. Blood sugar less than 100. You know, it used to be 120 20 years ago. Now it's 100. Again, we're sort of nipping at the edges here. 100, 120 I think is fine. Body mass index. I'll show you some stats for the US. You know, we've become overall a very large population, seriously. And anything you can do to keep your body weight mass index below 25, which is considered optimal. 30 is considered obese. And, you know, people tend to be somewhat vigilant about 25. But I think just keeping your weight in check, I think that's the best way to look at it. Don't smoke, but you can see your risk from coronary disease. If you quit for a year, your risk goes down precipitously. Now, the risk from cancer takes many more years. But for heart disease, if you could stop smoking for a year, your risk goes back to baseline. Physical activity, we'll talk about what's reasonable. You know, you don't have to be a gym rat to obtain cardiovascular benefit. You can train, you can become very conditioned and feel good about yourself, but as far as your heart's concerned, you really don't need a lot of physical activity to obtain benefit. DASH-like diet is a low-sodium diet. It's dietary approaches to stop hypertension. It's the only diet that's ever been shown to improve blood pressure control, and in truth, it's just lower sodium, not zero sodium. If you look at large population studies of women, there was a Swedish study with 22,000 women. This excellent profile was less than 5% of the real world. So we talk, but you know, if you just approach these goals, I think it's better than saying, I have to do this, this is where my cut point is, because it's not realistic. It's hopeful, and it's what we ought to strive for, but I don't think it's something you really need to achieve 100% of the time because it's impractical. So how do you risk stratify? Who's high risk, who's low risk? Well, people with diabetes are considered today to have coronary disease. So if you have diabetes, meaning you're treated with metformin, glyburide, insulin, any of the other insulin sensitizers, you have diabetes, that's the equivalent of having coronary disease. Does that mean you're going to have a myocardial infarction in 2 years? Absolutely not. But we should treat that as coronary disease. You have atherosclerosis, and you should be considered to want to undergo intense intervention. So all of those previous factors we said, you should strive to reduce or optimize all of them. If you have had a stent, you obviously have the disease, and the disease is progressive. So once you have established at some point that you have the disease, you are considered at risk for having more events down the road, which makes sense. And other diseases like chronic kidney disease, that has a very high risk of atherosclerosis if you're on dialysis or if you have very poor kidney function. Other risk factors, some we can't help. Age over 55. Smoking, you clearly can help. Hypertension is definitely worth treating. I started treating mine 2 years ago. I saw the light. HDL of less than 40 is worth working on. Exercise works. Niacin works. If you have a HDL cholesterol of greater than 60, you have good genes. That's a very good protective effect. So if your doc says your good cholesterol is high, that's twice as important as your bad cholesterol being high. Family history. So what's family history? I think we have a slide for that because everyone's got a family history of heart disease. But when is it meaningful and when does it affect your prognosis? Diabetes places in high risk. So family history is defined as if a first-degree female relative, mother, has an event less than 65 years old, or a father or someone close has an event less than 55 years old. So lower in men because it occurs later in women. 65 is sort of the cut point for risk factors. So if mom or dad or even grandparents had events in their 80s, yes, there is a family history, but it really doesn't impart a lot of risk. The risks tends to be when it tends to occur in the very young, 55, 65, which I'm being convinced is more young. So how do diabetics do compared to non-diabetics? As you can see, much worse. Once you have diabetes, the mortality from heart disease goes way up. So you see that green line? It just kind of shoots up after 4 to 5 years because the disease progresses much more rapidly in the presence of diabetes. Those metabolic derangements that we measure as causing the sugar going up cause many more changes in the blood vessels that cause the cholesterol to deposit and progressively cause issues that can result in events: stroke, heart attack, heart failure. The highest risk groups are the colored women, Latinas, African Americans, Asians, Pacific Islanders, the highest risk of diabetes. So, interestingly, we looked at this in Springfield, and there's a little bit of a disconnect. So even though their diabetes rate is excessively high, and I mean it's like 35, 40%, I mean it is a very high diabetic rate with a very poor diet and other risk factors, they tend to have less coronary events than some other populations. Be that as it may, there's a very high diabetic rate in these ethnic groups. So when you risk stratify, and there's 2 calculators, and I'm not sure I can get the link to work from here, but the NIH has a calculator you can use. You can plug in your age, your blood pressure, whether you have diabetes, and if you know your cholesterol, and it will tell you, are you high risk, low risk, intermediate risk. What's high? Greater than 20%. So over 10 years, if you have a 1 in 5 rate of developing coronary disease or a heart condition, that will occur if you have established heart disease, carotid artery disease, when they scan your neck, or people have had a stroke or an endarterectomy, peripheral artery disease, which they scan your legs and look for that ABI, which is becoming much more popular these days, or an aneurysm. So if any of you have undergone Lifeline screening, you'll know they look at your neck, they look at your aorta, they draw some bloods, and they do an ultrasound on your heart. So aneurysm, in parts risk, diabetes, and again, chronic kidney disease is a bad player, although fortunately it's relatively rare. So who do I care about? This group, the intermediate risk. Women who have sort of metabolic syndrome, and we'll talk about what that is. It's sort of this conglomeration of a little bit of high glucose, waist greater than 35, a little bit of hypertension, you know, just sort of that form fruste of a person who has a little bit of this and a little bit of that. You may have women who have multiple risk factors and one high risk factor, like mom who had a heart attack at age 63. And it may include women with an elevated coronary calcium score, although I will say in the Northeast, we don't do that procedure very much. Down in Texas and in some states, docs are big on doing these scans on your heart looking for calcium in the arteries. Because where you see calcium, you're thinking there's probably significant atherosclerosis. Although, again, that data is suspect. It's a wonderful non-invasive way to look, and it actually is less susceptible to that issue we talked about with the earlier imaging studies where the woman's small heart would sometimes cloud your interpretation. The calcium score is relatively efficient and accurate. The 2 websites, the NHLBI, but I just don't know if I can tweak it. No, okay, I just need an internet link. But I'll give anyone who wants it afterwards. It's very simple. If you just type in NIH coronary risk, the calculator pops up. It's very useful. Mine is 7%. What's metabolic syndrome? Big waist. You know, men with the big waist and no hips, that's a bad sign. Women waist circumference greater than 35. High triglycerides, although not such an important player. I know some of you may be on fenofibrate or Tricor. There are efforts to reduce the triglycerides, although it's not as important as the LDL and the HDL. Low HDL is bad. I mean, but you can't do much about that. That's inherited. You know, there are behavioral things you can do to reduce your risk. There are some you're born with, we're all dealing with. So a low HDL tends to be genetically mediated. You can do some things, exercise. Some people think a glass or 2 of red wine will raise the HDL, and niacin. But niacin is very tough to take for any of you who've tried. And a fasting glucose of greater than 100 or an elevated blood pressure. So these are sort of these intermediate processes that aren't quite an illness, but in a group, they tend to give you an impression of someone who might be at risk. The lower risk group may have one risk factor, or you may have women with no risk factors who are just leading a healthy life. And so then you don't worry about so much. You don't push the Lipitor on them if their cholesterol is 210, but they exercise, they don't smoke, they have very low family history. You don't have to go chasing that cholesterol down to 160, because you really don't do much for that patient, and the risk of that patient developing a significant coronary event is relatively low. Very few people have optimal risk, although we strive. So what are those things? You know, smoking, physical activity. How much physical activity? If you look at a wonderful study from Boston, Women's Health Initiative, 30 minutes, 3 to 4 times a week is enough. Walking, swimming, biking, elliptical trainer, whatever can capture your fancy for 30 minutes, 3 or 4 times a week is enough to impart coronary benefit. It will reduce your cardiac risk. You may not go to Sochi, but you will reduce your risk. Weight reduction, healthy diet, psychosocial factors, less stress. I'll show you a very interesting slide. If anyone you were here 2 or 3 years ago, it's one of my favorites. You know, omega-3 fatty acids really, I'll show you, I think I have a slide on that, and I have a slide on folic acid. No harm, no foul, not much benefit, okay? We all wish that the fish oils would reduce the risk, because we all know that the Eskimos and those populations that eat oily fish tend to have low heart disease. When given as a supplement and as a pill, it's not as effective as one would wish. Cardiac rehab is important after you've had an event. I can't stress that enough. So God forbid anyone undergoes a bypass surgery, valve surgery, stent. It's very important to participate in cardiac rehab, psychologically and physically. It really, really is very useful. I can't emphasize. Everyone should stop smoking. I think the same treatments benefit both men and women on this risk factor for sure. Women face different barriers to quit. I'm going to gain weight. And I have several patients like this. I'd love to quit, but I don't want to gain the 10 pounds. And I can't deal with it if I can't smoke. You know, we do our best. I think counseling at the office visit, Wellbutrin is reasonable, nicotine patch is reasonable, and emphasize that the risk of gaining weight, although from a self standpoint may not be optimal, it does reduce your risk significantly. Smoking is the #1 factor we can reduce risk. So smoking compared to non-smoking, you can see the risk goes up. If you smoke up to a pack a day, the risk is almost 6 times higher that you'll have a coronary event. Tobacco causes the arteries to become somewhat active, irritable, and if there's plaque in there, that plaque can rupture, which puts the clot, which causes the heart attack or the stroke. So it's the inflammation in the vascular system due to nicotine and the other active substances that we think allows tobacco to be such a bad player. Again, encourage 30 minutes of moderate. What's moderate? You can talk, but you're not panting. 3 miles an hour on a treadmill, I think, is fine. Incline, no incline. Just do it. Just do it. You don't have to be crazy. Just if you do it 30, 40 minutes a day for 3 to 4 days a week, that's more than enough. You really don't have to go every single day. If you want, good for you. Unfortunately, 1/3 of women really have no leisure time physical activity. Women have competing risks. I mean, they take care of families. Many of you work now and take care of families, and it's almost like you're running on a treadmill at home, which we have not translated into being as beneficial as a dedicated physical regimen. So I have people come in and say, look, I'm on my feet all day. I'm doing laundry. I'm up the stairs, down the stairs. I hear you. But to take that time to yourself, if feasible, and participate in that physical activity, I think psychologically and physically you will benefit. White women do much less than white men. Now, whether that's a cultural thing, whether that's a jock thing, I don't know, but it's clearly the case that women do exercise less than men. And the highest risk group with the diabetes, they're the worst of all. So again, these are observational data. How to intervene to promote this, I think this is probably as good a forum as any other propaganda we can put on the television, which they've tried unsuccessfully. So anything you can do to keep yourself involved in physical activity, I think is very useful. So how about body weight? Does body weight matter? Well, if you look at weight gain since age 18, if you've gained 10 to 20 kilograms, which is 20 to 40 pounds, which is pretty liberal since age 18, you raise your risk about 2.6. If you've gained more than 40 pounds, you really raise your risk sharply. Now again, that high bar on the right is probably associated with diabetes and hypertension and all that other stuff that comes along with weight. So in and of itself, although I'm focusing on weight here, I'm probably incorporating a lot of other disease processes that are going on in conjunction with the weight, associated with the weight. But clearly, if the weight goes up, there's probably other things going on that's going to raise your risk. So this is a great slide. So if you look at how many people are obese, what proportion of the population are obese in this country, and the distribution, you look at the 90s. So in the 90s, you had about a 10, less than 10, very little data on obesity. As you get up to 99, you see it goes up to 20 to 24%, 15, 19, mostly in California and the Northeast, higher in the South. And then by 2010, it's over 30% of people in the Deep South are obese. So the population is, and it's, I know you hear it on the television, it's an epidemic. We have this problem. It's due to fast, cheap food. It's due to physical inactivity. It's probably all of the above. But it clearly is huge. It is huge. And it's not getting better, despite campaigns, because fast, cheap food is very attractive. You all see Taco Bell commercials at McDonald's. It's hard to break the cycle. So what's the goal? Keep your BMI below 25. And whenever you go to your doctor, you can ask, what's my BMI? Very few people ask me. They go to the dread scale with the nurse and say, oh, I was 5 pounds less before I got here. But you ask what the BMI is, because the BMI is sort of an overall, because some people are 6 foot tall, some people are 5 foot tall. And the different weights, there can be a guy who looks like a horse, weighs 300 pounds, but he's not that bad. So the BMI sort of adjusts for height, weight, and your body size. And that will tell you how big your body should be compared to what your proportions are. Waist less than 35, that's probably a safe bet. Again, that's just sort of a marker, but we probably all should have a waist size less than 35, and it should be measured just above the navel, not to cheat, because a lot of men like to take it down in the groin. If you want to lose weight, you don't have to do it in a draconian way. It can be done gradually, 10% body weight, develop a plan, reduce the calories a little bit. It doesn't have to be, I'm going on a, Atkins diet, which is great, but then when you stop, it comes right back. The best diet, I think, and again, you will find other speakers who say other, I think the Mediterranean diet's the best. I think incorporating meat on a more infrequent basis, poultry, fish, cheese, yogurt, they're big on nuts, pasta, rice, couscous. Anything you can do to incorporate those in your diet, I think, is beneficial. They do recommend wine because it's the Mediterranean, and that's part of the European diet. And adequate hydration. I know we all talk about it, but 6 to 8 glasses of water a day is probably useful. It probably is. Again, some people say, I can't. It's just not part of my psyche. I don't, drink water. But, if you can do an extra glass or two, I think it's useful. I think most of us probably are dehydrated most of the time during the day. And daily physical activity. A lot of people like to add soy if you can eat it. It's not bad. Tofu is actually pretty good. A low glycemic index. Avoid the white breads, too much of the processed foods. Calorie control can be automatic. If you eat the foods that we tell you are healthy, it's probably less caloric. Now, granted, it's probably less satisfying on occasion. There's chocolate cake, which is great. But on the other hand, there are substitutes that are probably tolerable, palatable, that are very beneficial, and actually probably translate into reducing your risk. Here's the thing that bothers me. Depression in women predicts CHD more than women of death. And these are things that I don't think we talk about a lot. You come in, you see the patient, it's your 15-minute visit, and it's on to the next. And so I think, we just have to be very savvy about people who may be struggling with a lot of stress or subclinical depression, and at least ask, how's the quality of your life? Do you feel depressed? Do you feel like you can't escape? Do you feel like you're running on a treadmill all the time and you can't exercise? And so I think it's an important thing to realize, and it was an independent predictor in a very large study. So, I think this is important to realize. Here's my favorites. How about stressors? Among women who were married or cohabitating with a male partner, marital stress was associated with a threefold risk of events. Men can do it, huh? Yeah. Living alone and work stress did not increase events, but cohabitating with a man did. So stress is important. That's what I mean to say. This is only one piece, and it is, it's a little bit of trivia. But, psychosocial stressors, depression, are very important. We can measure numbers. We can tell you, you get a little note in the mail, nice job with the cholesterol. But if you're not feeling it, it's not going to translate into a lot of physical benefit, or as much, I will say that. Now, what about the omega-3? The American Heart Association says, as an adjunct to a diet, it may be considered in the high-risk woman. Who's the high-risk woman? Diabetes, already had an event, you have a stent, you have bypass surgery, or perhaps for that metabolic syndrome, the waist greater than 35 inches, the blood pressure that's sort of marginal, a little bit of diabetes. My fasting sugar is 110, but my doctor said my hemoglobin A1C was only 6, so I'm kind of on the cusp. I have to watch it. It's okay. I have to say, in all the studies we've done, we really haven't seen the benefit we all thought. We tried to give it to people with heart failure, people who had heart attacks, people who had bad heart arrhythmias, atrial fibrillation, because we thought, the fish oil will get into the membranes of the heart and calm everything down. And it never really did as well as we would like. We don't know why. We think perhaps because pharmacologically giving it in a pill is not the same as getting it in a fish, or whatever that lifestyle is that the person who eats the oily fish, that culture, why they derive benefit from that diet. So giving it in the form of a pill is not as good as assuming the diet. But it is considered reasonable if something's happened to you or you have diabetes. Folic acid, again, hard to take. We pushed it for years before the Lipitors of the world came along. Very tough because it causes a lot of side effects. It is probably useful if you have a high homocysteine level. Back in the 80s, when the cholesterol theory was being solidified as, hey, if we lower it, we help people, there was another group down in Rhode Island, for the most part, that were looking at homocysteine, which is another metabolic molecule in the atherosclerosis. So when you develop plaque in your artery, homocysteine is an important player for how that plaque gets deposited. So folic acid can lower your homocysteine levels. Problem is, we gave it to the people with the renal disease. Remember, I said people with kidney disease have a high risk of atherosclerosis. They have huge homocysteine levels. So you're going, hey, that's the target. Let's go for that population. Large study, folic acid versus placebo, homocysteine levels dropped, no difference. So, great postulate, sounds right, does no harm, but, if you take it, it's probably okay. I'm not sure it's really going to do much. How about this CRP? I don't know, some of you may have had it measured in you at some point. It was a hot item for a while. This Dr. Ritger from Brigham and Women's in 2000 came out with an article in the New England Journal and said, hey, look, these are markers of inflammation. So if the blood vessels are really irritable and they're inflamed and you have this plaque sitting in there, I can measure this in your blood and tell you if your risk is higher. Clearly, the risk was higher. How do you lower it? We don't know. I mean, you can give aspirin, which is recommended a lot for women, and it does lower the CRP. But it's never been shown that, yes, observationally higher is worse, but how do you get it down? And if you get it down, does it translate into benefit? And that's really never been shown. There was one study where they gave Crestor, which some of you may be on, and that seemed to lower the CRP and seemed to translate into better outcome. But again, most of us have stopped measuring this because we're not sure what to do with it. It's interesting. We went after it for a while, but again, I think less your doctor is going to be saying, well, your CRP is high. But it was big for a while. Fibrinogen was big. Again, a marker of inflammation. The blood vessels aren't happy. You know, I'm prone to clotting, and that's what we worry about. We worry about that blood vessel with the plaque in it disrupting just enough to cause the blood to go from liquid to solid, to form the blood clot, and in the head, a stroke, in the heart attack. Clearly higher, but again, we don't know how to adjust and treat very well. And they've tried everything, steroids, non-steroidals, Motrin, all kinds of things. So what are the things we really can do that matter? Blood pressure, I think, is key. Like I said, I bit the bullet. I agree. I think if you keep your blood pressure, target 120. Real world, you go to the office, it's 140, over 80, 86. I think that's okay. And if your doc says, I can live with that, I'm okay with that. Because in the real world, that's the numbers you get. You know, you can take 5 different pills, get your blood pressure down, you'll feel terrible, and you won't want to take them. And I don't blame you. So, I mean, I think admirable goals are 140, 90, and most recently, you may have read in the paper, they came out with new guidelines. Elderly people, age over 75, 80, they want you to be a little more permissive. Let the blood pressure drift up a little bit, because we found we can often over-medicate people, cause them to pass out, break a hip. So you want to be careful. You know, a number is a great endpoint, but the patient is much more important than a number. So the new guidelines have said it's not so important to be 120 over 80. Just try to approximate it. Don't be walking around with 180 over 100 or 190 over 110. The lipid guidelines below 200, and I think there may be another slide. And if you do have diabetes, again, your doc will tell you this, but a hemoglobin A1C below 7 is what people aim for. If you're running 8 or 9, and you come in the office and your blood sugar is 130, that's not a real estimate. The hemoglobin A1C is a 3-month running average of what your sugars are. That's why it's good, because as the sugar coats the red cells, we can actually measure the amount of sugar on the cells. So when they take the blood out, we can actually measure the proportion that are sugar coated, and you want it less than 7. High blood pressure, again, encourage the optimal. I started taking it when I hit 140/90. That made me a little bit nervous. Some people think with diabetes or kidney disease, you should shoot even lower to retard the process further. Again, the science behind that isn't great. I think 140/90, if you can get there or below, good for you. Thiazide, HCTZ, you know, that great drug, I hope you're all on it. 5, 10 years ago, no one was on it. 20 years ago, everyone was on it. Great drug, cheap. Everyone left it behind when they marketed these brand new wonder drugs. This is probably one of the most effective, inexpensive drugs, and it's very useful. And I take that too. So again, maintain the body weight, eat the healthy lasagna. The DASH eating plan, fruits, vegetables, low fat, and low salt. Sodium restriction, 2400. I mean, 2400 is hard enough. If any of you have had heart failure, you know, those heart failure clinics or the docs, I mean, they want it down below 1800. That's impossible. If you actually count the amount of sodium you eat a day, it's hard to get below 2000. If you stay around 2400, I think that is reasonable. No one does 1500. No one who lives in the real world. Increase your physical activity. 1 to 2 drinks per day. It tends who you talk to. You know, you look at the curves, and people who drink 2 to 3, they do a little better, but people are very concerned about promoting alcohol consumption, although, you know, in every study, it's never been shown to hurt your heart. I must say that. If you can get the LDL below 100, so when you're in the doc's office, the HDL above 50, triglycerides below 150, good news. If it's over 160, the risk is high. So it's, so when I see women who have an LDL of 140, do I treat it? Not always. I mean, so if you're very active, you really have no family history, you're in for palpitations or some other process, and it's 140, some people used to be really bent on getting it down below 100, and I get it. But, if everything else is okay, the likelihood you're going to really help this person by giving them the Lipitor 20 or the Crestor 10 or the Simvastatin, whatever the insurance company pays for, you're going to derive meaningful benefit. It just becomes lower. You have to ask yourself, is it worth it? There was this great enthusiasm about looking at the type of LDL. So there were these people who had these very small particles, and you could send the blood off to Boston, and they had these great labs that were doing these tests. And it's actually now discouraged because we don't know how to treat those people any different than an LDL of 160. So subcategorizing the bad cholesterol into different bad was in vogue probably about 10 years ago. And now people just say it's not indicated is the word they use. You definitely change your metabolism after menopause. You change the way cholesterol is metabolized through your liver. Your liver makes most of your cholesterol. You need cholesterol. Your skin, your eyes, your brain, tissue. Cholesterol is a very important component of body tissue. It's when it gets in the blood vessel that it's bad. And so we think if it's floating around in those blood vessels at 160, it's probably not the best thing. And we used to get into the subfraction after postmenopause, but now, again, I think the number 160 is probably reasonable to target. There's not many people over 160, really. You should keep saturated fats to a low, cholesterol down, and reduce and trans fatty acids are really leaving the food market. I mean, I think they're banned in New York and probably elsewhere. So they're not part of the market. They're very cheap, they're easy to make, and the food like margarine can sit on the shelf forever. And that's why people use them, because as a food producer, you had something that would sit on your shelf, tasted good. People like the way it tasted, but it clearly is not healthy for the body. You should keep the saturated fats probably to less than 10%. I know they say 7, that's hard, and if you're a label reader, you'll see it's very hard. Dietary cholesterol of 200 to 250, I think, is reasonable. Weight reduction, I can tell you, is very laudable if you can do it. A lot of people are into plant sterols and esters, vegetarians, soy proteins, probably useful, does reduce the LDL. So these dietary modifications, independent of drugs, can lower your LDL. So if you don't want to take those darn statins because the muscle pains and what you've heard, diet does work. It's not super, but it'll get it down 10%. And if you're running at 160 and you get it down 16, you're at 144. That's not bad. I'd live with that, really. If you're going to use anything, use a statin. And again, I think, I'm not big on, if you've had an event, I would say an LDL of 100, or, they say 80. I mean, getting an LDL to 80 is hard. It's Lipitor 80, it's, Crestor 40. So, I mean, it requires high doses of these statins. And again, I think a number is admirable, but the patient is more important than a number. So if you can get it down somewhat, I don't think 100 or 80 is like this magic number. And I think you'll find your docs by saying, look, it's 110, you're doing the right stuff, you're eating the right food, you're trying to exercise. I think 110 we can live with. It's not like 100 creates this magic low-risk panel. It's a gradient effect. Low HDL is more important in men than women. So what I said was that the good cholesterol, for every point that it's higher, it's the equivalent of 2 points of bad cholesterol. In women, it's actually 3. I know it's genetic. I know it's very hard to change the HDL. Exercise, moderate alcohol, and perhaps niacin. Let me just cut to the chase here, because I know this is getting old. When to use aspirin? I think we used to push aspirin on everyone, 325 milligrams. That was the way to go. British, absolutely not, 81 milligrams. Then some of you may have been on this thing called half-prin, where they had you on 162 milligrams. It was sort of this compromise between the people who study platelets swear that 81 milligrams is the optimal dose to keep the blood lubricated. We used 325 because that's an adult aspirin, and that's the dose we give, and that's what we're used to. And so it became sort of controversial. I think the way it's sort of played out is somewhere between 75 and 162, which in our country is a baby aspirin, 81 milligrams. If you look on the shelf, you will find 75, you will find 162, but 90% of the less than 325 milligrams are 81 milligrams. Definitely if you're high risk, if you've had an event, you have diabetes, strong family history, and you smoke, especially the smokers, I tell them, please take an aspirin. There is a slight increased risk of bleeding in women, more than men, with aspirin, cerebral bleeds, but it is low. And in high-risk people, it's probably worth the risk-benefit. In low-risk people, I wouldn't take it, because I really don't think I'm giving you any benefit, and there is that tiny risk of subarachnoid bleeding. Or central nervous system bleeding, I should say. Intermediate risk, okay, as long as you've done everything else and you're not apt to develop a GI bleed or some other issue. Again, the benefit is not as much, but if you've done everything else you can to control and you think you want to take an aspirin and to lower it further, you're probably deriving some benefit from the aspirin. Most people tolerate it quite well, which is why we are. So, in people who have coronary disease established, aspirin versus no aspirin, you can see the difference in heart death, which is on the left, the white, and then on the right, the blue is all-cause mortality. So it reduces heart death, 5.1 to 2.7, and it reduces all-cause mortality, which is probably clinical strokes, subclinical heart attacks, so we don't know that it's a heart event, but it does contribute to mortality. So clearly aspirin is beneficial at some point. High risk, established coronary disease. In lower risk women, it may benefit, but I don't think so. I think over 65 you might take it, but I would balance it against the risk of internal bleeding. I think the last line is the line to read. In low-risk women, which I think many of you are probably low to intermediate, it should be balanced against the risk of internal bleeding, which can be central nervous system. And I've seen it. So it's rare, but it can happen. So it's good to think about before just saying, sure, take an aspirin. Not useful. Hormones. Remember the years? Oh, we were going to give you estrogen, progesterone. We were going to save your bones. We were going to prevent heart disease. When they did the study, it did not. It did not prevent cardiovascular death, and it actually increased the risk of some clotting, where people had blood clots in their lungs. So even though, and most of these studies were run by women, so I know it's not just us, that the excess with estrogen and progesterone, they had worse risk. So the risk, it's not very high. 7 per 10,000 women years. So if you had 1,000 women who you followed for 10 years, there were 7 more events. But it clearly wasn't less. So the hormone didn't help. It might have hurt. But you know, the consistency of the results across the endpoints, stroke, cardiac events, pulmonary emboli, that's the blood clots to the lungs, and the breast cancer risk with the hormone. And I remember in the 80s, I mean, everybody was getting estrogen, progesterone. I mean, it was the thing to do. And then they said, hey, we don't know what we're doing. I mean, and so they did these large studies and said, whoa, stop immediately. And you know, today, to put someone on estrogen, progesterone, it's almost heresy. So if you look at the risk, estrogen alone, without the progesterone, it does reduce hip fractures. It definitely does. It preserves bone density. There's no doubt about that. But it does increase the risk of stroke. And I think most people would say, and So anything above 1, it's harmful. Anything below 1, it might be helpful. Estrogen alone, hip fracture, breast cancer was lower. The progesterone estrogen is what caused the increased risk, breast factor risk. Mortality was no better, maybe a tad worse. This was the only significant finding, that star, where stroke risk was much higher in the estrogen group. So that's a no-no these days. Estrogen plus progesterone caused a small 7 per 10,000 risk of coronary heart disease. The use of estrogen without progesterone increased the risk of stroke, the last slide we saw. And all hormones should be limited to the short-term menopausal relief. So everyone understands hot flashes. There's probably very little surrogate drugs you can give. Block cohash. People have tried all sorts of and those are phytoestrogens. Those are estrogens that occur in nature in plants. And they do work pretty well. So if you're really struggling, it's reasonable to take on a short-term basis, but not as a long-term strategy. We've never found an antioxidant that worked. I mean, you can go to GNC, and we used to have the superoxide dismutase was big in the 80s. There were all of these other antioxidants that we swore, when added to our food stuff, would help, and we've never been able to give it to a patient in a pill form and give benefit. It may be useful in foods, and if you say this food is high in antioxidants, this is something I should eat regularly, I think that's well and good, because there's many things we don't understand what you're eating and how that is interacting. When you put it in a pill or a fruit juice, it probably doesn't do much of anything. I think at the end of the day, it's important to know a couple of things. Gender differences exist. It's clearly a different beast. Different symptoms, different presentation, and you get treated differently. I think today we're better than we were 10 years ago. I think today, with the regionalization of heart attacks and how they're managed, how everyone gets whisked off and taken to the cath lab and has a stent put in rather than, well, let's give the blood thinner and see how they do. I think that standardization has helped, and I think it's helped women. I know it's helped the population overall, and as people are living longer, coronary disease becomes a larger issue in women than men. It's important that we recognize it. It's important we don't treat every patient the same. Every patient's individual. They come with their own blueprint, and gender is one of those important factors that I think people now truly understand should affect your thought process about the management of the patient and how they're going to do. Now, some things you can't change. I mean, you just can't change. If the woman shows up 10 years older than the guy and she's got diabetes and hypertension, it's going to be a bit more trouble. It just is. But you have to have the mindset to understand it. This whole evidence-based guidelines. So in the old days, we used to take a study, or the professor told me so. And then there was this huge shift in the 70s and said, look, do a study, really see if the darn thing works. And a lot of the things that I grew up with saying, wow, this must work because, in the textbook, they drew a pathway that went this way and went that way, and the patient should do better. Well, when we tried it and looked, they didn't do better, and some did worse. So biochemistry and what you read, what you get taught, doesn't always translate into the way people behave. So it's important to look at evidence. What's the evidence? If your doc wants to give you something, just say, what's the evidence? Is there a lot of evidence, some evidence? And we now have level of evidence. Level 1, level 2, level 3. And so there's a scheme for saying, there's good evidence for this, there's no evidence for that. I think this is probably the right thing to do. That's okay, as long as you do no harm. And it doesn't cost too much. The bottom line is, I think it begins with you guys. I mean, the fact that you're here, the fact that you invited me to speak, the fact that Baystate Mary Lane even does this thing. I mean, I think and you're wearing red. I think it's really important. And the whole campaign, this whole heart campaign, women and heart disease, way overdue, way overdue. And I think it's important. I don't think it's a bunch of fluff. I think it's actually people motivating to take a step, replace those unhealthy habits, eat for heart health. It doesn't have to be soy every night. Calories do count. And it's tough, when you're working and you have a lot of things, it's tough not to eat. Walking, I think, is great. Walking is simple, it's cheap. Weather in New England is tough. But, I know the people here who all walk in the park around by the church. I think it's great. And, when they do it, they're into it. And again, if they do it 3 times a week, they're very proud of themselves. And I think it's good. And that's all it takes. It doesn't take, an Olympic attempt. View the changes as not quick fixes. It's a lifestyle change, I'm going to change this because I know it's important. I know I'm up here yakking, but, these are things you can actually embrace as part of your life. Set realistic goals, buddy up. If you can go walking with someone, you're twice as likely to walk with them 3 months later than you will be walking by yourself. Don't worry if you don't go walking for a week or 2 because it snowed out. It's okay. You can start again. Be proud of yourself. Reward your success. Be your own advocate. Always ask in the office. I know it takes a few extra minutes and the doc's in a rush and, I'm taking too much of his time. Ask. Just ask. There's no dumb questions. There isn't. Because, maybe I haven't thought about it. And when you mention it, I say, that's a good thought. I think depression is one of those things that we should talk about. They've come up with the simple 7. This is the American Heart propaganda. So the goal is to improve the health of Americans by 20%, and this is directed towards women in this event, and cardiovascular disease by 20%. So what are the simple 7? Blood pressure control, exercise, cholesterol, diet, weight, smoking, and sugar. The last thing is a glucometer, measuring your sugar. So they think this is the new thing you're going to be seeing in the news, the simple 7, how we're going to help. It's reasonable. It's hard to actualize on a day-to-day basis, but if you keep it in perspective, I think these things truly do have the effect of retarding heart disease, helping you live longer, and without disability. And I think all those things are reasonable goals. So it's up to you to protect your health, and we're happy to help. Thank you.